much, everyone who came tonight, and we really appreciate the effort. I know some of you traveled far, so we have a really good lecture tonight. Our expert speaker is Dr. Imran Chaudry. He's an associate professor in neurointerventional radiology here at the Medical University of South Carolina. He's a fellowship director of the neuroendovascular surgery program, and he does a lot of research here, and he also sees clinical patients. So we're really happy to have him, and he's going to be speaking on a very important topic that will be very informative. So welcome, Dr. Chaudry.
Thank you very much for the invitation. Sorry, I'm on call as well, so just trying to make sure I'm not getting paged. All right, so Dr. Patel asked me to talk about idiopathic intracranial hypertension. I think the focus here was kind of a CSF support group. There were some patients with EDS that may have been here as well, or were supposed to come, and so there's some overlap with those patients. And so he just wanted me to talk a little bit about what idiopathic intracranial hypertension is and what we can do, and some of the newer stuff that's coming about and how we treat these patients. So idiopathic intracranial hypertension was also known as pseudotumor cerebri. The old terminology for this was benign intracranial hypertension. And these patients present with signs and symptoms of raised intracranial pressure. So commonly they present with headaches, transient visual changes, and pulsatile tinnitus. Now that term benign intracranial hypertension is a bit of a misnomer because when left untreated, this can progress to visual loss or blindness. So to me, that term benign is very misleading, especially when you can lose vision, which is something that we all depend on every day. Most commonly, idiopathic intracranial hypertension is most commonly seen in overweight females, but there is this atypical patient group. There's a suggested increased incidence in Ehlers-Danlos patients of the hypermobility subtype, and then as well as in Chiari malformation patients. So for the most part, we use the modified Dandy criteria to diagnose idiopathic intracranial hypertension. For the most part, it is a diagnosis and exclusion, but there are some criteria that we use to kind of hone in on that diagnosis. So these criteria are essentially symptoms of raised intracranial pressure, so headache, nausea, vomiting, transient visual disturbances. That can be anything from changes in visual acuity, blurry vision, double vision, to little focal field cuts as well, and then also papilledema. For the most part, there's no localizing signs. So signs are things that a physician can elicit. Symptoms are usually complaints from a patient. So for the most part, there's usually no localizing signs with the exception of an abducens nerves palsy. The abducens nerves is the sixth cranial nerve, and it's the nerve that controls the lateral movement of the eye. So when you look to the outside, a lot of patients will complain of double vision. That's something that we can also see as physicians because you'll notice that the eye does not move to the outside. For the most part, when we do image these patients, the CT and MRI are usually completely normal. There's no evidence of any kind of tumor or any other kind of pathology that could be causing these symptoms. The only other symptom or finding that we'll find on studies is a high opening pressure when we do an LP. So an LP is basically placing a needle into the spinal canal, looking to see what kind of pressure there is. So it's a direct measurement of the pressure of the intracranial space. And so in these patients with idiopathic intracranial hypertension, obviously that pressure is raised. We look for at least a minimal measurement of at least 25 centimeters of water. And for the most part, the composition of the CSF is also normal, right? So sometimes you can have abnormal biochemical and cytological composition of the CSF that may indicate some other kind of disease process, which would exclude the diagnosis of idiopathic intracranial hypertension. And then again, because it is almost a diagnosis of exclusion, there's no other explanation for the raised intracranial pressure. So those features that we talked about, headache, nausea, vomiting, pulsatile tinnitus, and those visual signs and symptoms, they're very distinct in idiopathic intracranial hypertension. For the most part, the headaches are usually dull. They usually are in the back of the head. They tend to have like a temporal relationship with the day. They're either worse late at night or first thing in the morning. And they're usually worse when lying down. So a lot of patients, when you get a headache, what's the first thing you want to do? You want to go lie down, right? But in idiopathic intracranial hypertensive patients, it actually tends to get worse when they lie down. And then there's nausea and vomiting, pulsatile tinnitus, which is a whooshing sound or ringing in the ears. And then the visual signs and symptoms, which can be transient visual loss. It can be holes in the field of view, so you can have black spots in their vision. Diplopia, double vision related to that sixth nerve palsy. So especially when they look to the side, when they look to the left or to the right, they may get double vision when they look one way or the other, but when they're looking straight, their vision is relatively normal. Again, those blind spots, and then papilledema, which is swelling of the optic disc. The optic disc is that junction of the optic nerve, which is the structure which sends all of our visual signals to the brain that we can understand. So where it joins the globe itself, it starts to swell because of the increased pressure. Am I keeping it simple, too high, too low? Good? Okay. Yeah, if there's anything that you guys don't understand, feel free to stop me.
Can we move the mic closer? Because I think it's working.
Well, I've got another one here. So can you guys hear me? Oh, okay. All right. Is that better?
Yes. Yes.
Yeah?
Yes.
Okay.
Thank you.
They're already asleep in the back.
Yeah, it was really hard to hear.
Okay. So that's better. All right. So identifying papilledema is actually fairly easy for the ophthalmologist, right? So they'll use the ophthalmoscope, they'll look in your eye, and they're basically looking for the optic disc. So the optic disc is this structure here, and what they're looking for is the color of it, as well as the appearance of the blood vessels as it comes out, okay? And so there's 5 grades of papilledema. Obviously, the higher the grade, the worse the papilledema, the higher the risk of visual loss, okay? And that's what really we're trying to prevent in these patients. Obviously, we want to improve their symptomatology, but we really want to prevent visual loss, and that's all related to the papilledema. So stage 1 is, you get this C-shaped halo with a slight blurring of the blood vessels as it comes out of the optic disc, and it kind of progresses to where the margins kind of continue to blur. Stage 3, there's almost obliteration of the disc itself. You really can't identify it. It starts to kind of protrude out. Stage 4, you can't even really identify any of the blood vessels coming out at all. And then stage 5, there's complete obliteration of the optic disc as well as all the blood vessels. And obviously, you got to have blood supply to those nerves, right? The eyes, the retina is essentially all nerve endings. It's got to have a fairly robust blood supply to provide the nutrients and whatnot, and then just to maintain the normal healthy tissue so we can receive those signals. So with uncontrolled intracranial pressure, that pressure is transmitted to the optic disc, and you get this continuous swelling. And so this is really what we're looking for, what we're really trying to prevent from happening. So the mechanisms of idiopathic intracranial hypertension are not fully understood yet, but we believe there's basically 2 methods that this can occur. One is from increased CSF production, which is that fluid that bathes the brain and the spinal structures. It provides nutrients to the surface of the brain as well as the spinal cord. And so we think that it's either due to an increase in the production of that CSF or a decrease in the absorption of that CSF. So that CSF is formed in the ventricle system, which is kind of here and here, and then the 4th ventricle. And there's structures within the ventricles called, I'm actually blanking on it right now, which is kind of embarrassing. The choroid plexus, sorry, choroid plexus. So it's formed within the choroid plexus, and then it goes from the ventricle system into the subarachnoid space, and then from the subarachnoid space, which is actually that space right immediately adjacent to the brain, it brings the nutrients directly to the brain. There's a gradient of pressure that transmits that fluid from the subarachnoid space into the large venous collectors of the dural sinuses. And it's that pressure gradient that allows the movement of the fluid from one space to the other. Okay, and so we think, for the most part, that most of idiopathic intracranial hypertension, the mechanism of the disease itself is due to decreased CSF absorption. Okay, so CSF, we kind of briefly mentioned that how the outflow into the venous compartment depends on that pressure gradient or a transmural gradient from one space to the other, so you need that gradient to push the fluid across into the dural sinuses. What we do know is that we think that the increased resistance to the venous outflow is caused by either functional malformed or obstructive narrowing of some of these large venous collectors, the dural sinuses. And I'll kind of show you examples of that here. So the obstruction of the intracranial venous drainage, we think it's due to sinus stenosis. The sinuses are these big, large venous collectors. We have what we call the superior sagittal sinus, which is the main sinus that comes across the midline of the head. It divides into two. We have the bilateral transverse sinuses, the sigmoid sinuses, sigmoid because it looks like an S, and then they drain into the jugular veins. Okay, so these are the major venous drainage pathways of the brain. So we think that there's a cause, which is the stenosis here. And so these stenoses can be either anatomic or functional. So anatomic are usually sometimes the way that we're born. We can have what we call segmental hypoplasia or aplasia. It's just genetically the way that we're built, and everyone's built a little bit differently. So when you see a small sinus like this, even though it's the way that we're built, it could be a functional obstruction, right? And then there's also pathologic obstructions, sinus stenosis, like a very focal stenosis, which can be due to a web-like structure that's causing a narrowing in the vein. And sometimes there are structures that sit here that help absorb the CSF when they come into the venous structures. These structures called arachnoid granulations, okay? And so they're kind of an outpouching within the vein, and sometimes these can hypertrophy, and they're called giant arachnoid granulations, and they can cause functional obstructions in the venous pathways. So what we don't know is what came first, right? Was it that raised intracranial pressure? Obviously, the brain is covered by the skull, which is a hard structure. So when things start to increase in pressure, there's really no place for it to go, right? It's covered by the brain. When the pressure increases, the only place for things to go are outside the few small holes within the skull, right? So the foramen magnum where the spine comes out. So when the pressure gets raised, it forces structures out those small holes, right? So what we're not sure of, what came first? Is it the increased intracranial pressure that causes a narrowing of the vein because it's forcing a collapse of the vein? Or was it a narrowing in the vein cut that causes a buildup in the pressure? And so we're still trying to figure that out. Now, which came first? Was it the raised intracranial pressure causing the stenosis, or was it the stenosis that's causing the raised intracranial pressure? And we're not sure if we're ever going to figure that out, right? It's the old chicken and the egg phenomenon. I really do like that joke, though.
Yeah.
So the management is really based on, in my mind, preservation of the vision, which is the most important thing, right? And then to me, symptom relief is always important. But again, because of that misnomer, that benign intracranial hypertension, my biggest goal is always preserving the vision. If I can improve the remaining of the symptoms, great. But my focus is always on the preservation of vision, because that can have the biggest impact on a patient's quality of life. Obviously, these patients do have debilitating headaches a lot of times. They can have daily headaches that will debilitate them. They can't work. They become very lethargic. And so, we'd like to improve that, but my main focus is always on the preservation of vision. And so we can do this through a couple of methods, obviously medical management as well as surgical management, and we'll discuss each of those kind of briefly. So there are some things that we can do without medicines. The biggest thing, obviously I mentioned that most of these patients are morbidly obese females, so weight loss is the biggest thing, right? Now the hardest thing is you've got somebody who's debilitated with poor vision, frequent headaches, they're always tired. So it's hard to motivate somebody to get up and either focus on diet or exercise. But if we can do that, a lot of these patients get significant benefit just from a 5 to 10% reduction in weight. And then there's some newer research that suggests that bariatric surgery actually may be hugely beneficial in these patients. Again, most of it because of the reduction in weight that comes with it, but there are some other mechanisms that they're looking into. But bariatric surgery it's a fairly big surgery, right? It takes about a year of psychiatric and psychological evaluations to make sure the patients are ready for the big change in life, changes in diet. There's a whole spectrum of stuff that needs to go on. You can't just go in and have a bypass surgery, right? So it takes a little bit of time, and sometimes some of these other methods of treatment can maybe temporize the symptoms enough to help them motivate to get some more weight loss or to get into a position where they can have bariatric surgery, which can improve their symptoms quite a bit. Medical management basically focuses on decreasing the production of CSF, so there are some medications that we can use. The most commonly used is Diamox, which inhibits the production of CSF. The problem with this is it's a diuretic, so patients are peeing all day. It also gives an awful metallic taste to everything that you eat and taste. So everything tastes like a really bad fork or metal. Additionally, patients just don't tolerate it very well. Most of these patients have to be on about 2 grams a day. At that point, they tell me that the medication makes them lazier. It gives them sometimes worsening headaches, the metallic taste, and then combined with just sitting around peeing all day, they don't really tolerate it very well. So we're looking for alternatives besides some of these other medications. And then there's the surgical treatments for this, right? The mainstay and the gold standard has always been the CSF diversion procedures, the LP shunts and the VP shunts. We'll talk about those. And there's optic nerve fenestrations, and then there's this newer thing, endovascular stenting, or the stenting in the dural sinuses, trying to fix that narrowing that we talked about. So surgery is usually reserved for those patients who've failed medical therapy. We'd like to try the non-invasive methods first. So we start patients on Diamox if they can't tolerate it or they fail their therapy, meaning they're getting no benefit, their papilledema is continuing, their symptoms haven't gotten any better, then we'll offer them some kind of surgical intervention. Additionally, those patients who have fulminant cases, meaning they present with acute vision loss or extremely high raised intracranial pressures, they may not have time to benefit from the Diamox, and it could be threatening their vision completely, at a very early stage. And so those patients may require an acute surgical intervention rather than trying to wait for some of the medications to become effective. So the CSF diversion procedures have kept this very simple, and we're just going to focus on the LP shunts and the VP shunts. Technically, they're very simple to perform. There's a very low complication rate from the procedure itself. For the most part, they're fairly effective. Okay, about 80% of patients get some benefit. There are some serious but rare complications that can occur because obviously you're violating the brain parenchyma. There's a risk of damaging some of those structures just by passing the drainage catheter into those spaces. But those are few and infrequent. But one of the biggest issues with these procedures, the LP shunts and the VP shunts, is a high rate of failure down the road requiring surgical revision. So roughly about 50% of all the LP shunts and VP shunts at some point require a second procedure to repair the initial shunt. And a lot of that is due to the shunts get obstructed and sometimes the valves malfunction. And so while the procedure has some benefit, it can end up causing the patient a lot more discomfort down the road because they're frequently coming back for repeat revisions of these surgeries. So we're always looking for a surgery that's effective and it has long-term durability, right? And so that's where this one kind of fails. But it's considered the gold standard. And a lot of that is historic because when intracranial hypertension was diagnosed, we didn't have a lot of other options, right? So by default, this has become the gold standard treatment for intracranial hypertension. But again, it is a good surgery in the fact, for the reason that a majority of patients demonstrate stabilization of their vision loss. They get improvement in their headaches. And so, it is definitely something that we need to consider and that we still offer patients. So for the most part, roughly about 80 to 85% of patients get significant improvement in their headache. And nearly 100% of the patients, those visual changes, the papilledema, the thing that I worry about the most, goes away almost completely. And when we say the headache improves, it's so variable, right? So you have a patient who has debilitating headaches every day, that keeps them in bed. An improvement is it's a very subjective term. It could be that, I now have just very mild headaches every day, or I get no headaches, but I get a really bad headache once a week. So that term improved is somewhat subjective. But again, these are all patient self-reported data, so at least, they're seeing some benefit from it. The optic nerve sheath fenestration is it's a good surgery, and the idea is basically to create a little window in the optic nerve sheath. So the optic nerve sheath is a continuation of the coverings of the brain across the optic nerve and to the eye itself. And because that pressure is transmitted directly from the spaces of the brain, the subarachnoid space, through the optic nerve sheath to the eye, and that's what causes that papilledema. That's what they're trying to show you here. This is the swelling of the optic disc. This is the covering of the optic nerve, and this is the optic nerve itself. What they've done is they've done a little release, allowing that CSF to drain out, releasing some of that pressure. Now, it's a very good surgery, and it's usually reserved for patients who just have papilledema and vision loss and no headaches, because it doesn't really have an impact on the overall raised intracranial pressure. It really does kind of just focus locally on the optic nerve itself. So again, some of the advantages, usually only has to be performed once, so it's a very durable surgery. Sometimes these patients need 2 surgeries, 1 for each eye. But again, it's a one-time procedure for each eye, which is nice. It doesn't require the implantation of foreign bodies, so there's very little risk of device failure, device malfunction, or infection from a foreign body, which is great. And then again, obviously the less chances of infection and device failure. Disadvantages, it's not frequently performed, right? So finding a surgeon that's comfortable doing it is a little bit harder. So usually centers that are very busy or have a busy idiopathic intracranial hypertension clinic, or some of the other diseases that require CSF shunts, you'll usually find a surgeon that's very comfortable with it. So going to a general hospital, they're not usually very comfortable with it. A good neurosurgeon in any community hospital can do a VP shunt or an LP shunt, but finding a surgeon who's comfortable doing the optic nerve sheath fenestration is usually a little bit harder. And then obviously there are some significant complications that can occur, obviously because you're dealing with the optic nerve itself, right? So any kind of surgery or puts the optic nerve at risk as well. So there's a risk of vision loss, double vision, hemorrhage into the sheath causing vision loss as well. And then we're going to kind of move on to endovascular stenting, which is kind of where a lot of the focus of treatment has moved to. So again, endovascular stenting is focusing on these dural sinuses. Again, we talked about that superior sagittal sinus, that main sinus that comes down the midline, divides into the 2 transverse sinuses, which come around the back of the head, and then the sigmoid sinuses. So for some reason that we don't really fully understand, most of these patients always get a narrowing right here where the transverse sinus joins that sigmoid sinus. And so we're always looking for what we call a transverse sigmoid sinus stenosis, which is where we usually find it. We think it has to do where the dura, which is part of those coverings of the brain, insert around the sinuses. And so this is what we're looking for. We're looking for patients who have severe transverse sinus stenosis. So again, here's our transverse sinus, here's our sigmoid sinus. You guys can all see that signal dropout, signifying a very tight narrowing. Then the other thing that we look for is what we call a pressure gradient of 8 millimeters or more. So what we're looking for is a pressure difference from one side to the other, signifying that not only is it a visual stenosis, but it's also a functional stenosis, meaning that the stenosis is causing a backup or a buildup in pressure on the other side. We want to relieve some of that pressure. And then, so we're also looking for patients that are refractory to other treatments. So they've failed medical therapy, they've had an LP shunt or a VP shunt, and they're not getting the relief that they want. Then we'll consider them for a stenting procedure. So it's not a first line of treatment as of right now. It's kind of reserved for those patients who failed other therapies. But I think we're moving that pathway because of some of the stuff I'll show you here in a second. So I'll just show you a couple of case examples. This is a 29-year-old female, so a relatively young female, right? Comes in with headache, blurry vision, papilledema. And she got improvement with an LP, so her opening pressures were 40 centimeters of water. We look for at least 25. And then she was failing medical therapy. She was on 2,000 milligrams of Diamox, 2 grams of Diamox a day. And so we did our venogram, which is taking these pictures. Again, the superior sagittal sinus, transverse sinus, and the sigmoid sinus. She has this narrowing. And then we have the pressure measurements, and we can see that there's a significant gradient, almost about 14 millimeters from the top to the bottom. And so those are the candidates that we're looking for. And these are just some kind of other views just to kind of lay out the narrowing, showing you where it is. And the idea is what we'll do is we'll go in. Again, we're laying it out. There's that narrowing. Sometimes it doesn't look that bad, right? So you saw the MRI, it looked a lot worse. When we go to take the pictures, it doesn't look as bad as what we think it is, but the most important thing is that pressure difference. So it tells me that it's a functional stenosis, right? It doesn't matter how ugly it looks, as long as there's a difference in the pressure, that's probably the most important thing with it. And so the idea is basically to place a stent across it. This is just a large guide catheter that we've snaked up through the veins of the body into the vein of the head, and we've kind of crossed the narrowing, and then we'll drop that stent or deploy that stent across it, forcing that stenosis to open up. And the idea is you're basically creating a bigger conduit. You're fixing that stenosis, allowing the flow to improve through that segment. And so you can see from before, you've got, oops, sorry, a little jumpy here. You can see that narrowing there. We've placed that stent, and that narrowing has gone away. Most importantly, the pressure difference has gone away, right? And that's really what we look for to see if there's been an improvement, at least from the measurement side of things. And then so we follow these people up. Approximately a year later, she comes back to us with significant improvement in her headaches and blurry vision. She's reduced her Diamox now to almost just 500 milligrams a day. It's a dose that she's able to tolerate, and her papilledema is completely gone. And again, to me, that's the most important thing. I always tell my patients that my biggest concern is preserving your vision. If your headaches get better, I'll take credit for it, but if they don't blame me. Just another example, this is a 20-year-old female. So again, we're dealing with young women that when left untreated, they've got a whole life to deal with this stuff. So if we can improve their quality of life early on, I think it has a significant impact in their life. So 20-year-old female, persistent headaches, blurry vision, left eye field cut. So she's had a significant amount of pressure on her optic nerve where she's lost a whole field of view, so she can't see out to the left side. Her visual acuity is pretty bad. It's 3,500 and 3,200 in the right and left eye. So that's a fairly significant visual loss. I mean, you're kind of reading like right here. And then obviously she's got raised pressures, her LP, 46 centimeters of water, so very high. So again, that was the case that we showed you earlier, just the images, but the superior sagittal sinus, the transverse sinus, the sigmoid sinus, and the narrowing. And then on venography, again, it doesn't look as bad on our pictures when we do the invasive pictures, but most importantly, she had a really high gradient, right? So normal people have no gradient to 4 or 5 millimeters. So if you can imagine, she's got she's got what, almost 15 to 20 times higher gradient than most of us, because you can imagine the pressure not only on her veins, but on her eyes and the effects of that. And so again, the idea is to go across that narrowing. Actually we have a video. So, and it's just showing you deploying that stent across that narrowing, opening it up, and then showing you again the stent open. And most importantly, we do pressure measurements before and after, showing a reduction in that gradient. So you've taken somebody who had a significant gradient of almost 44 millimeters, and you've reduced it to almost 0. Now, her pressures are still high, right? So normally they should be in the 8 to 9 range, so she's still high, but that gradient's improved, so she should get improvement in her symptomatology. So again, she had mild improvement in her headaches, but her visual fields improved, and she had just a little bit of blurry vision. So her visual acuity improved significantly from what it was before. And again, to me, the most important thing is that preservation of vision and preventing it from progressing to visual loss. And so this technique is becoming more and more common. Unfortunately, there isn't a lot of literature to support it, but because of the interest in it, there is coming out a lot more literature looking at case examples, case reviews, small series to justify these procedures. And so this was a recent kind of meta-analysis of all the literature that's currently available. What's amazing is, you go to the cardiology literature, when they want to treat something, they have thousands of patients that they can document and use that for support to justify some of their studies. So in this, which is one of the larger series, we're talking about 140 patients. So it's hard to get patients, it's hard to get good data to show what we're doing is beneficial. So again, 143 patients and 7 case report and 8 case series. So those are usually probably small patient series of like 10 or 15 at different institutions that they've combined into this review paper. And so what they found was that almost all the patients presented with headache and papilledema, right? And almost half of the patients had visual changes, blurry vision, double vision, field cuts, and then pulsatile tinnitus, that whooshing sound in the ear. And just a very simple analysis, what they found was that they were technically successful almost all the time in getting the stent there. Some of the newer devices make it a lot easier. That used to be a big technical challenge, getting it across some of those turns. They're able to do it very safely, so very few complications, only about a 6% complication, and those were relatively minor complications. There was nothing big, bad, or ugly. And then over a 2-year period, what they found was that almost all the patients had significant improvement in their headaches and resolution of the papilledema. So resolution is important. It's not improvement. It means the papilledema is gone. So you could go from a stage 3, stage 4, stage 5, and it goes back to almost normal. Now, sometimes the damage has already been done, so you can resolve the papilledema, but they may still have persistent visual symptoms. But again, you know, the resolution of the papilledema is also very important because it'll arrest the further progression of that visual loss. And then, again, also a lot of the patients had improvement in the visual symptoms, and almost all of them had resolution of the pulsatile tinnitus. So it's starting to show us that these procedures are beneficial, they're safe, and they may have a better benefit over some of the other procedures, such as the VP or the LP shunts. So kind of in conclusion, stenting of sinus stenting for idiopathic intracranial hypertension hasn't been proven, but we're start to show benefit for it. And the nice thing is nice thing for patients is this may obviate the need for an optic nerve sheath fenestration, which is to me a little bit scary. You know, having someone go mess with my optic nerves or the VP shunt, you know, making a small hole in my skull and passing a catheter into the fluid spaces of the brain, and especially with the risks of having you know, a shunt failure 50% of the time over 2 years, repeat surgeries to fix the shunt. Usually most of the time with the sinus stenting, it's a one procedure done. Sometimes, because we do have 2 sinuses, sometimes patients who have narrowing on both sides, we usually do one side first, see if they have an improvement. If they don't, then we'll go back and we'll do the other side. So sometimes patients may have to have 2 surgeries, but after that, they're done. And then you can still, you know, if they get some improvement but don't get all the way, you can continue with medical management, weight loss, things like that. And again, most of these patients get significant benefit from these procedures. That's about it. Thank you. So, happy to entertain any questions if you guys have them. Sure.
So if the patient is having those symptoms, who would they go to first to try to figure out what's going on?
Yeah, it's a good question. So I think there's different pathways, right? I think sometimes they go to the neurosurgeon because of the pressure headaches. Sometimes they can go to a neurologist. I think a lot of patients actually end up going through ophthalmology because it's usually the visual symptoms that disturb them the most. So it really takes a good ophthalmologist or sometimes even an optometrist to recognize that they may have these issues and refer them to you know, a neuro-ophthalmologist or a good neurologist who can recognize what this is and get them in the appropriate physician's hands.
So a neuro-ophthalmologist is the best?
It's probably your best choice to start. Yeah.
Okay. Okay, and then who would make the decision as to how it's being treated?
It's usually a multidisciplinary group decision, but again, a good neuro-ophthalmologist who has a good understanding of the disease process, they'll usually manage them initially with medical management. If they feel that they're failing medical management, they'll refer them on either to a neurosurgeon or someone like me who can do one of the sinus stent procedures. Anyone else?
This may be a silly question, but from a surgical perspective, scale of 1 to 10, 1 being a walk in the park, 10 being exceedingly difficult, where would you rank the venous?
The sinus stenting? It's about a 1 or a 2. Yeah, and even for the patients, I mean, they go to sleep for it. It's a little half-inch incision in the groin, and they basically wake up with a Band-Aid over the groin that's about that big, versus, you know, the burr hole and the headache. So most of these patients do have a headache for a couple of days afterwards, just because we're stretching the sinuses with those stents. But that headache usually resolves over a couple of days. But from a technical standpoint, they're very easy procedures. A lot of that's due to advancements in devices and techniques, but it's probably one of the easier things that we do. Sure.
Is there any additional risks for somebody who has tortuosity of the vertebral and basilar arteries?
No, because this is purely on the venous side, so it has nothing to do with the arteries. So they can have the most ectatic vessels in the world. The sinuses are usually relatively straight. It's a good question. Anyone else?
With the shunts, are you seeing when they fly, the shunts affected, or having an MRI?
With an MRI, yes. So they usually have to be reprogrammed after the MRI because it's a metal shunt usually, and sometimes the valve or the settings will change, and so they'll have to be reprogrammed after an MRI. But that's a fairly simple procedure.
Okay, but flying shouldn't
Yeah.
affect it.
Shouldn't.
Thank you.
Sure. Anything else? Well, thank you for having me. I appreciate it.
Thank you very
Sure.
much.